Good afternoon, everyone, and welcome to the Baldrige Foundation's Institute for Performance Excellence webinar, Systemness, Operating as One. Before we get started today, I want to take a moment and recognize all of our great sponsors and a special thanks to members of the Mac Baldrige Society who serve as trustees for the Foundation's Institute for Performance Excellence. Here is today's agenda. Today's guests include Dr. Roger Fullman and Dr. Chuck Peck, co-hosts of the Baldrige Foundation's Leader Dialogue program. Dr. Gay Landstrom, Senior Vice President and Chief Nursing Officer, Trinity Health. Kim McGuire, Executive Vice President and Chief Nursing Officer, Northwest Community Hospital. Dr. Darren Frisillo, Co-founder and Chief Medical Officer, About HealthCare. And Ben Sawyer, Industry Expert with About HealthCare. Following their presentation and discussion, we'll have questions from the moderator and a few closing remarks. And now I will turn it over to you, Roger, to help get us started.
Great. Thank you so much, Al. And thank you to the Baldrige Foundation for making this all possible. It's so much fun for us to be able to do this and to bring you really high quality content and some fascinating panelists who have great opinions and great insight into what's going on and the challenges that all of you as healthcare leaders are facing today. And again, I'll say this, I say this all the time, we're not just about admiring the problem, but we're really about trying to find solutions, practical things that you can apply in your organization today, even, so that you can really be the leader that you're meant to be and the leader that your organization really needs. So thank you, Al, thank you, Baldrige Foundation, and thank you to our panelists. We've got, as usual, just a great group of panelists and and some really good friends of mine. We are very close and are going to have a lot of fun today. If you haven't listened to the last Leader Dialogue podcast featuring Dr. Gay Landstrom and Kim McGuire, please do that. I wish you would do that. Write a note and go back and listen to that. We had a great conversation and some great practical advice for you. And we just had to extend this conversation, which is what we're doing. And the topic, as you see, is Systemness, Operating as One. And we have some topics that we will probably cover. I'm guessing we will: leadership development, employee empowerment, and then seamless handoffs. These are really critical features of trying to move from sort of a reactionary mode to being responsive and proactive in what we're trying to accomplish in our health systems. So Ben, you are managing the slides. So if you could just move to the next slide a second, I just want to use this to tee up our conversation. This is something that should be familiar to all of you if you're at all familiar with Baldrige work. And this hierarchy of needs really reminds us that in order to get progress, to make progress, we need to start at the foundation, and that's colleague engagement, and then move through this pyramid. And some of you know that I do a lot of coaching, executive leadership and coaching. And one of the things that I've been saying a lot to the individuals that I've had the privilege of working with is, in times of extraordinary change and crisis, my advice is to focus on the 5% of life, of your life, that you absolutely have control over. I hope that doesn't shock you that it's such a small number, but focus on that 5%. And in that 5%, I put things like your attitude, your fitness, your health and fitness, your spiritual well-being and health, emotional well-being and health. Focus on those things, and then everything else should fall into line. And so that's what we're trying to encourage and bring you people that have done this and know how to do this. And Ben, you might want to just make a comment about your Baldrige work and your Baldrige experience and how you've used this pyramid.
Yeah, so thanks for all of that, Roger. That was a great intro. I think from a Baldrige perspective, everything within an organization is obviously interconnected. It's hard to work on one area and it doesn't influence something else. And so that's important as you're talking about moving out from the disruption of the pandemic into whatever the new normative is going to be. And the relationship of these things are important. So Roger, what you were just talking about with colleague engagement really being the foundation of any high performing organization, and any desire to accomplish your strategy, which is at the top of the organizational pyramid, is not going to happen if you don't have good colleague engagement. And even the layer above there, right, organizational effectiveness, which is related to category 6, won't happen unless you have these foundational pieces. Last thing is the pervasive categories that are critical to sort of feeding and nurturing the organization are leadership, effective leadership that has this element of persistent learning and servanthood, which we're going to talk about a little bit, and then measurement, analysis, and knowledge management. So knowing where you're at, where you're going, tracking progress, all those sorts of things are all critical to driving and achieving customer value and overall performance.
Great. Thank you. Thank you so much, Ben. We've got another slide coming up after that one that I just wanted to comment on. There we go. And again, this is perhaps review. Hopefully it's review for all of you who are listening to us, but some of the topics that we'll get into today, and I know that our guests practice this, we put the patients and consumers at the top of the pyramid. We invert this pyramid so that we use whatever our positional authority and responsibility and power is to empower our leaders next, our employees and providers, and the patients and consumers, and to serve their needs. So you'll see how this is all connected in our discussion coming up. Well, let me start now with that tee up and get to our panelists. And we've intentionally invited Gay Landstrom and Kim McGuire, who are former colleagues. They used to work together, and full disclosure, the three of us worked together in a different system. But now Gay finds herself in a very complex organization at Trinity Health, responsible for nursing practice and many other things, but chiefly nursing practice in this huge system, very large, complex system. And Kim now finds herself, having been in that system, now finds herself in a community system, a community health system, and a little bit different perspective. So I'd like to just ask the two of you to comment on what is it about system, being a part of a system that is beneficial, and what are the things that are more difficult, perhaps, when you have the decision-making taking place further away geographically from the operating system. So Gay, would you start off that conversation, please?
Sure, I'd be happy to do that, Roger. And in full disclosure, I am a big fan of systems. I honestly think I would have a challenging time being in a single system where I did not have the advantages of being in a system. Some of the things that I think about when I think about working within a system is the opportunity to really leverage the skill of the people within a system, whether it's just a couple of organizations or dozens and dozens of organizations within a system. There is great talent. And being able to find that talent and leverage that talent is really the challenge. And it is a waste if organizations don't really try to mine for that talent and engage people in tackling the challenges that we all face within health and within healthcare. So I think about that skill being just so rich and so powerful. I do reflect back on the last couple of years with the pandemic that we have all dealt with in this country and globally. We had so many unknowns early on. And we also had rapidly changing guidance. Actually, it just changed over and over and over as we learned more about this virus and its variants. It it really was an opportunity for us as a system to find experts throughout the system and put them together on a council that met almost daily. Because there was so much that could be read, so much information, and information that needed to be, we needed to decide if it was good information. Was it information we should act on, or perhaps we needed to be cautious with that information? And so being able to harness infection preventionists and infectious disease specialists and people who really understood this work and had prepared for pandemics was just such a blessing, to be honest. And so lots that can be leveraged there as a system. And frankly, we were able to make decisions rather than hundreds of different separate entities all trying to figure this out individually and figure out how to give direction to our colleagues and care for the patients that presented themselves. Instead, we harnessed that skill, made a single decision, and issued guidance for the entire system. And as we began to really get in a rhythm of, let's not waste our time, let's not duplicate efforts, we can do this together, and we can do it more swiftly, and then everyone can benefit from that knowledge. It really allowed us to be able to I think weather and manage the best we could through all of this. And there are other real benefits, but one of the things that I would caution is that whenever it's much easier for an individual to make a decision on their own. You know, think about the knowledge that you have, weigh the options, make a decision, and that can be done fairly rapidly. Might not be fully informed, but you can make a decision quickly. When you need to gather people, from different organizations, when you have people in different time zones and little tiny hospitals wearing 10 hats and others carrying great responsibility for a single area, that can be challenging, and the danger is that it gets too lengthy. So systems need to both harness the skill within their system and find ways to do it efficiently.
Thanks, Gay. I have had the same experience in my career working for a system, of course, and then also small individual hospitals. And there are definite advantages in terms of, as you say, collectively, collecting the knowledge and scale and scope of so many people that affect the system. So yeah, thanks for that. I want to talk later. I'll just put a bookmark in it and write a note. But you mentioned early, so many things changed in the loss of trust and the confusion that occurred. And I just think we're still seeing some of the vestigial hangover of that loss of trust and confusion. I want to get back to that later. But Kim, could you talk about, now you're in it is a system, but it's a more community-based system, isn't it? And
Yes.
So where do you, what are your executive leadership team meetings look like compared to what you were used to previously?
Well, I think what Gay said is spot on. I couldn't say it any better, honestly. I'm a big fan of systems as well. I've gone from a very, very large system to a very new, actually, smallish system, community-based system. And so it is a little bit different. Some of the aspects are the same. You have the camaraderie, you have experts that you can tap into. There's the obvious efficiencies that you get from belonging to a system. Obviously, our meetings are smaller with less people involved, but there's a lot of connections in the Chicagoland area, especially a lot of connections inside and outside of the system that we leverage. I would agree with Gay in that part of being one of the advantages of being part of the system is you can collectively think through the issues at hand and have the experts weigh in and come out on the other side with probably a better outcome or a better plan. But I think as a large system, especially, you have to be able to allow some nimbleness and some nuances to cite specific issues. And at least in my experience, a smaller system has allowed for that a little easy, maybe easier than a larger system has been able to do that.
Great. Thanks, Kim. And we didn't, if you're not familiar with this group of people, we didn't give a lot of details in our introductions, but Dr. Darren Versillo is a hospitalist nocturnist, and great, interesting position for these times. And then Dr. Chuck is he works for Guidehouse, but he is a rheumatologist. And again, both of these gentlemen have been very familiar with working within systems, within hospitals. How has this, and Chuck, with your client base, which is really large, some of the largest systems in the country, how has this impacted your clients and Darren, the people that you work with? We'll go to Chuck first.
Well, I think the last couple of years have certainly been a little bit different, right? I think the tendency is when stress really goes up, people tend to go back to their old ways where they felt comfortable before. And so I think that in some cases, systems have sort of decentralized back to the way they were before they became parts of well-functioning systems, right? So if you've got a large system with multiple spokes, multiple hospitals, multiple physician groups, some of the ones that were already stressed prior to the pandemic have sort of lost some of their systemness and gone back to operating as individual pieces, parts like they were before. And I think, this is one way that I think you can stress a system and see whether or not it truly become an operating system, or whether it really has stayed a holding company but says that it's an operating system, right? And everybody says they're an operating system because they've read all the articles in Harvard Business Review about how you have to be an operating system, but you have to act like it. You can't just talk like it. And I think the high functioning systems, the systems that are here to stay as systems that have done well. And when I say done well, I'm not just talking about finance. I'm saying have done well. They're at the top of their league in terms of quality, safety, patient satisfaction, employee retention. Well, that's what I mean by success. And I think that's frankly what's driven their financial success as well. Those systems have managed through this last couple of years, when you look at them, in much better shape in a lot of ways. And I think what Gay and Kim said earlier about some of the advantages of being in the system, I don't think there's any question that when there's a huge challenge or crisis, whatever it might be, it certainly feels a little bit safer to be in a diversified portfolio, so to speak, where you have multiple colleagues, multiple entities. Some years, some people do better than others, and other years, the others do better. And, there is some more certainty and security in that. So those are just some of my observations.
Great. Yeah, and I think that we're seeing that this isn't a static, it's not binary. It's really, we're all at varying points and we're moving forward and backward and we're constantly evolving, aren't we? Dr. Versilla, Darren, as a practicing physician, have you really noticed any changes throughout the last couple of years in terms of your relationship with administration and their policies and procedures? How has that affected your practice?
Oh, certainly. What a catalyst these past 2 years have been for change. And it almost seems like it's accelerating even as those catalysts like the pandemic seem to be dropping off a little bit. And, part of what I do as a physician is clinical practice. Part of it is actually in administration. So being able to be involved in that has certainly been rewarding. Every hospital is a system. And it's a system of subspecialties and wards and people who are working together to get things done, and they function within a community. And to your point, the point Chuck made, it's partially about finances, but it's partially about serving the community and giving the best quality care to those who are there. And then you look at a system of hospitals, which really is a system of systems. And then there are things like a state hospital society, or what was happening in Arizona, where they brought all of them together to work with the Arizona Surge Line, where you've got a system of systems. And so it keeps building on each other. And I think those that I've seen that have been most responsive, flexible, successful during this time, who've have looked at the walls that they have of those parts of their systems and tried to break them down. And it's really been a perfect storm as demand ramped up with the pandemic. And then in certain areas, there were surges within the surge, such as bringing surgeries back and bringing people back to the hospitals. And then the perfect storm was the Great Resignation, where I know Gay and Kim could probably talk about this for hours, losing 20% of our workforce in nursing and in staff and all of these different areas. And so what does a system give you is the ability to respond to those things as you then look at the talents, the infrastructure, the resources that you have available, and you structure your system in a way where you can respond as a system, whether that's load balancing across hospitals and transferring patients or moving resources around or giving visibility within your system to different areas that can absorb some of that impact as it comes along. And traditionally, I think many even systems pitted parts of their systems against each other as a way of measuring success. CEOs, for example, looking at their financial success against each other and perhaps de-incentivizing them to work together across those silos. So I would just say that one of the most rewarding things that I've experienced as a physician has been either stepping up or having others step up to assist me. To your point, if I'm on call at night and the ER is full and we don't have a bed left in the hospital, just hearing that, that sister hospital or somebody saying, we got your back, we'll take care of your patient for you, or the advent of telehealth and being able to leverage more talent without actually physically moving the patients around, that's been extremely rewarding. Also taking the load off of others and working together. And then as a consultant with About, realizing that technology isn't the answer to everything. I love the slide, people, process, technology, working with organizations as they've come to us and saying, you know what, that lower level foundational engagement, let's get together with all of your providers and let's engage together and let's work on better strategies so we can work together and not work against each other, and do things like provider engagement or staff engagement and overcome some of those barriers. So again, a great catalyst over the past couple of years, stretching our capabilities, but really forcing us to look at how we do things and find a better way to do them with our resources. That's been what's been most
great. Thank you, Darren. Really encouraging. And that just leads to kind of the next thing I wanted to talk about, and that is, all right, let's get practical. Let's get extremely practical. I don't know when we're going to stop saying, the pandemic really changed everything. It did. Now let's move on. How about the future? How are we going to respond to the future because of what we've learned? And, there was clearly a period of adjustment, and that's where this sort of erosion of trust and confusion came in. Not only if we kind of dip our toe into the employee empowerment section here, not only internally, but externally as well. And, I was on the phone yesterday with somebody called me and, their husband was being admitted and they still couldn't, as spouse couldn't come into the hospital and be with their husband. And he's in sort of he's got a respiratory disease that could take his life. And, and so just the angst and the anxiety and the fear surrounding this. And it really has eroded the trust level between the health system, which, again, Kim and Gay, we talked at Trinity about our goal was to be, for our patients and stakeholders, your most trusted health partner for life, which is such a powerful concept. Well, that has, we've knocked the foundation out of that one because of this. And so how are we overcoming that? How are we going to get that back? And I don't know who wants to, jump in and tackle that one, but I know Kim and Gay have done some practical things, but Chuck, did you have a thought?
Yeah, I know. I just wanted to put it in the form of a question, if that's okay for Kim and Gay, just to get their thoughts. So I meet with I work with a lot of systems. I talk with a lot of chief nursing officers. And obviously nursing is one part of this, but it's a huge part of it. And, a lot of people are in the mindset right now of, well, thank heavens we finally are getting through the worst of COVID, it seems, so things can go back to the way they were. And my question is, do we really want things to go back to the way they were? And, I'm fortunate, and like Roger, and I have the perspective of having been doing this for a very long time in multiple systems, large and small, all different parts of the country. And you know, things weren't that great before the COVID pandemic. And, you know, it seems like when we start talking about employee empowerment and things around that, we got to do a heck of a lot better than what we were doing before the pandemic. And so I'm just really curious as to how they're thinking about, you know, going back to either the old normal or actually developing with their people a new normal that's going to be a lot better than what the old normal was.
Great question. Thank you. Gay, I think, is itching to answer that one.
He is itching, yes.
Yeah.
That's a great way of posing that, Chuck. I appreciate that. And you are spot on that things were not great. A lot of good work going on, but things were not all great before the pandemic hit. There were issues with trust. There were issues with people not being happy with their employers, perhaps not able to voice concerns as openly as they'd like to, just lots and lots of things. And then the pandemic hit. And as others have said, it just shifted the ground, the whole, so it doesn't matter what we talk about, the relationship between employees and their employer, trust, as Roger has mentioned, both from employees and from the public. There just has been so much shift. And as I look at that, I see it as very disruptive, absolutely, and damaging to individuals. We have employees and clinicians that they're really weary, and some of them need healing from what has been very traumatic duty over the last 2 years. That said, it is an opportunity. Everything is so disrupted right now that all that we talk about when we talk about getting the energy for change and helping people to release what they've, you know, sort of loved or hated for the last decades, everything's so disrupted right now. And so a lot of the work of starting change is already there. And so I urge people, let's not ever say that we want to go back to the way it was, because it wasn't that great. Let's talk about where we go in the future and use this as an opportunity to really listen and engage with our employees, listen and engage with those people that we serve as patients, as residents, in our communities. Let's really listen and co-create what we need to do in the future. And that kind of conversation has spurred a lot of innovation. And it is very hard for many of us in healthcare. We've honed our skills and our ability and our experience doing things in the past. And so being creative and looking at possibly very different ways of providing care, very different ways of employing and working with clinicians. It is hard work, but it is the work that we need to do, and we need to not waste this opportunity where change, the ground is already stirred, and it gives us the opportunity to move into a very different future. And I'll give up the mic for a moment, but I have some examples that I could share later if that's desired about some of the things that we are doing.
We definitely want to get back to that. Thank you, Gay. Kim, you mentioned in our podcast about, you said the word weary. Our nurses are weary. Yeah. And as Gay said, we weren't in a position of strength. We didn't have all of our positions filled. There were a lot of critical vacancies then, and there were frayed relationships and difficulties. So how have you dealt with this in your new, you kind of come into your organization sort of mid-pandemic is interesting way to arrive, isn't it?
Yeah, it is. Very interesting. First of all, I have to say, I just wanted to say, I felt like I was in church and I wanted to say amen when Gay was talking. Okay. I just wanted to say amen to everything she was saying, because it all resonates with me. And I think going back to the original question about trust, I think the way you get trust back from your community that you serve is through your staff, is through engaging your staff, because the staff, to your point earlier, Gay, they're weary. They're not trusting right now. They've been through so much. And I think that as leaders, it's going to take different leadership. We can't go back to the way it was. We have to do things differently, and it's going to take new, innovative ways to be a leader in this environment. And I think we have to empower our leaders. We have to train our leaders. We have to give them education to show up differently. The first thing I did when I got to my new organization was go on listening tours and just come in on all shifts, be very visible, come in on the midnight shift, come in on weekends, sit and just listen to people, and just listen to what they have to say. And, there's some very dedicated people in healthcare, and they're here because they want to serve and they want to help, but they need somebody to support them and serve them. And I feel as a CNO, that's my role here, is to support those folks that are taking care of our patients. And we're just going to have to show up different as leaders. So that's one of the first things I did, is go on listening tours with my staff and providers, for that matter, hearing what they have to say as well. They want to know that we're caring for them as a whole person too, not just an employee. We're finding that we're having to do some things in the spiritual realm, with post-traumatic disorder that they're dealing with, and how do we help them get through some of these things. I just talked to a nurse the other day, and she's a hardened ER nurse, and 30 years, and she doesn't need any help yet. She found herself on top of her husband in the middle of the night trying to do CPR on him after she had a horrific death earlier that day. So it manifests in different ways with different people, and I think we just have to provide an environment where they can seek the care that they need to take care of themselves, emotionally and spiritually as well.
Wow. Kim, you've always, as long as I've known you, you've always been so good, so attentive to not just nurses, but providers, other providers as well. And so I'm glad you brought that point up. And I just think we can't pass by this without saying there is PTSD, there is trauma, there is extraordinary stress that's affecting our providers every day. And we can't make the mistake of looking at them and saying, well, they're fine, they're good. They have a lot of, they don't have a lot of control over their future, over their situation. The greatest complaints I hear from physicians is, I never see administration, I never hear from them, and everything, when I talk to them, all they do is say no, and we can't do it. So again, Gay, I want to get back to your practical examples, but before we do, I just want to pivot back to Chuck and Darren to see if they have any comments about changes in physician relationships and what they've seen that really is helping take the stress and tension and friction off of that situation.
Well, go ahead, Chuck.
Yeah, so again, as part of my earlier question to Kim and Gay, I've been thinking a lot about just sort of the day in the life of a hospital unit, right? The day in the life of a patient in a hospital unit, right? So the reason I was asking about, whether we really want to go back to the way it was, and Darren, I think, can really be helpful on this point. So we're not using technology anywhere near what it could do to help us get through some of these issues that we've been having for a long time. Just getting very, very practical and down and dirty. I mean, how many people are using the electronic medical record capabilities just because they were told to use them because these are the capabilities, versus when you really look at from a clinical point of view as to which capabilities really are helping and which are hurting? Why aren't we just getting rid of the ones that are hurting? Why aren't we thinking more about healthcare as a team sport? We've got the doctor comes in when it's convenient for them. The nurse gets into the room when she can possibly make it. Therapy comes in at a totally different time. The case manager comes in at a completely different time. We've got the patients, even with the same diagnosis, scattered all over the hospital. So there can't be a real focus on the overall patient, because the patient is being treated by different specialists all across the board without any sort of a holistic view. And, the whole idea about the way we run our day, if you really think about it, it probably doesn't make a whole lot of sense. And, if I asked people how much of their to-do list they could absolutely erase because it's not adding any value to them personally or any value to the organization or any value to the patient, it's probably, I'm guessing, 30, 40, 50%. And what if we were able to replace that by doing things completely differently and smarter. And I think that goes for the physicians and the administration too, quite frankly. It's the same old, same old. The administration comes up with the strategy. They don't include any of the providers, physicians included. They hand it down and they go tell people to implement it. They have no idea that what they just did in terms of developing it does not fit at all into the way doctors still think, which is still the index card that they pull out of their pocket where they have the things each day that they have to accomplish, right? I mean, I still work with physicians that, forget the iPad, so many docs were trained like I was on the index card. And that's just the way we think, right? I mean, we've got to get these few things done, period. And I just wonder, how we could better use technology to help us instead of continuing to get in the way of the patient-physician interaction. I think it's done a marvelous job in certain cases with improving quality. There's no question about it. But in terms of the day-to-day working together and operating together as a system, I think it's just caused real problems. So Darren, I couldn't give you a better segue based on your background, so I tried my best.
Thanks, Chuck. Go ahead, Darren.
No, Chuck, I think you make some great points, and it's I think this recurring theme we're hearing is there were a lot of issues that we were dealing with before, and just to say let's go back to the way things were would be doing the whole system a disservice. It reminds me of a great message I heard a lady who is a leader of a large women's organization just recently, and she said that she went and saw somebody at a high school reunion that she hadn't seen for 30 years, and this old friend said to her, "You haven't changed a bit." And the first thing she thought to herself was, "I hope I've changed over 30 years. My goodness, we do need to change and change for the better." And so, from the technology standpoint, Chuck, some view technology, yes, as a burden, and the way that technology is leveraged by leadership or administrations or even payers to be a qualifier for whether or not you're getting your work done can be seen much more as a burden than it is as a facilitator of great and efficient care. And so I think that definitely needs to be something that organizations look at is how can we leverage technology and people and process together so these things aren't a burden, they're not getting in the way of patient care. You talk about physicians, let's talk about nurses. How much time do they spend documenting every little thing they do, which takes them away from the bedside? And then they spend an hour after their shift is done just getting the rest of their documentation and recording done. That's a horrific strain. So I would just say that as organizations that we need to dig deep, look hard, look at great examples in industry standards or what consulting organizations or vendors of software who can bring to the table, not just the software itself and the technology, but the best practice and process alongside and be a partner so these things can be great facilitators.
Great point. And that is the reality of this. We're not going to convince health systems to move away from the EMR. We need the EMR. It definitely has proven itself in financial, for coding and for financial efficacy and billing and legal issues. And there are efficiencies that are gained in terms of getting orders filled, et cetera. But nurses didn't go to nursing school to be data entry clerks. Physicians didn't go to medical school to be data entry clerks. And when I talk to people, and you've all experienced this, it varies by age cohort. And the digital natives, the ones that have grown up with iPhones, they're not bothered by it. In fact, they feel, I look like a dinosaur when I show up at a meeting with my notebook and actually with a pen and take notes. But we've got to deal with these different age cohorts within the organization working together and be more sensitive to it. So, Gay, let's get back to your practical examples of some of the things that you've done to really sort of recast what it means to be a nurse and shifts and work and recruitment and that sort of thing. You talked about this on our podcast, and I'd love to have you illustrate some of those for our guests today.
Yep, happy to do so. I do just want to make a couple of quick comments. Chuck, totally agree that that care is an interprofessional team sport. It absolutely is, and I think if we're not working together on solutions, we're going to actually create inefficiencies, because during the pandemic, everyone just got down to doing what needed to be done, and there was incredible, in many cases, not all, but in many cases, incredible collaboration between the interprofessional team, just trying to figure out how they navigated. And so our approach needs to be interprofessional as we go forward. And as both Chuck and Darren were talking, I was thinking about a principle that I've been keeping in front of me now for the last year, and it's the idea of co-production. And I think it applies to not only care, and care processes and so forth with those that we serve, but also with our colleagues. And it's a really, if you're interested in reading more about it, there are certainly some great articles out there. But when we are talking about a service, it's completely wrong. For instance, for me as a clinician and now as an administrator, to decide what is best for you as an employee, or for me to decide what's the best process for a patient. We've got to work with the people who will use the service to even and co-produce that to even be close to hitting the mark. So co-production, I think, is something really important, and I think is critical to reestablishing trust with both of those groups. So a few examples. One of the things that we are learning in talking with our employees, and we did this a lot in the early days of the pandemic too, is that they wanted, even pre-pandemic, they wanted and needed greater flexibility with their life and their time and when they worked. And here we had, and we all have them in our organizations, these old FTE jobs where you work every other weekend, you work half the holidays, and you have to beg for vacation and wait till you've been there 20 years to be high enough on the seniority ladder. People were increasingly needing more flexibility. And it might be they needed to take care of an aging parent or kids or whatever. It doesn't really matter. They needed more flexibility, and we had a lot of rigid systems. And that just exploded during the pandemic when kids had to go home and you're homeschooling and all of that. So we created and tremendously expanded in the early days of the pandemic what I think of as an internal staffing agency. And basically it gave nurses and other disciplines like respiratory therapists and surgical techs a way to engage with the system, but tell us when they're available. And it was these are all experienced people. I mean, they're the kind of people you want working for you. And they would give us just a lot of their time, but they needed the flexibility. And we previously didn't have a lot of ways for them to engage with us. So creating a way for those employees to have the flexibility they need to deal with whatever in the rest of their life. And when you start adding hundreds and hundreds of those people, you have plenty of talent to cover weekends and nights and everything that people worry about, that that if you give people flexibility, they'll never work nights, they'll never work weekends, they'll never work the holidays. And it's just not true. So when you amass, a lot of people together, it's a great, great resource, and it meets their personal needs. One of the other areas that we have really been doing a lot of work with is really trying to reimagine care. We had to accept we don't have enough RNs in the country. And if you look at the data, there aren't enough LPNs or nursing assistants or medical assistants, or, I mean, there's just shortage everywhere you look. So how will we provide safe care and high quality care, it can't be, let's try and get back to our previous models of care just as diligently as we can and take some of those RNs from the competition. I mean, that's not going to work. So we really, we've been doing a great deal of work looking at innovative ways to deliver care. And it does involve looking at technology and how can technology support us, virtual roles to really bring expertise to, young members of the clinical team at the bedside, and many other ways, but virtual, bringing virtually in to the team expertise to help with complex care and mentoring and all of those things, I think is a really important thing for the future. And we're still learning and working on that. Another area is, Darren, I think you were talking about how much time people spend documenting. And if I look at what nurses say they like the least about their job, it's documenting. And what are they spending the biggest chunk of time on? And upwards of 40% of their time documenting. That is not a good combination. It's all this time, and it's the least fulfilling, least rewarding part of their role. And there's nothing, there doesn't seem to be any resilience benefits to documenting it. And so we are doing work right now looking at what can we eliminate in documentation that doesn't add value? How can we bring some technologies like dictation, scribing for nurses? Earlier this week, I was at my dentist's office and the hygienist is dictating all of her notes. They're able to do it. And the technology is available. Why don't we bring that to nursing? And we're having conversations, and we'll actually be starting that work here in a few weeks. To use that technology. So those are some of the things that we're doing, but it's not about going back. It really is about accepting that the ground shifted, and we need to understand that, work with our colleagues and our patients, and create something that is new.
All right, Gabe, thank you. Those are some exciting things. And by the way, let me just throw in a note here to our audience that as a result of talking with Kim and Gay in our podcast and in preparation for this, the Baldrige Foundation does do periodic roundtables for CEOs, system CEOs. And we've been talking about, is there a need to do the same type of thing that for nurse executives and nurse leaders. And so just stay tuned. This is something that both Kim and Gay have encouraged us to look at. Ben, I think you had a comment on Gay's.
Yeah, just a quick comment. We've talked a lot about people's margin and how it's been depleted. And when you're traumatized, your margin goes down. So we knew as lean experts that in most processes, there's about 40% waste. So, and people were already tapped and they were asking for help, which is what Kim and Gabe have been talking about. So there has to be a sensitivity to the fact that now people have even less margin. So this notion of co-production and how to basically multiply by staying flexible and collaborating so people can compensate for each other's margin and individuals can find a better path forward, I think is brilliant. And love to hear that kind of innovative thinking going on. That's great.
Good. Well, we have about 10 minutes left in our time together today. And I want to give Al a heads up here to maybe share some of the questions that may have come from our audience. Before we do that, can we just go to these some practical takeaways? Ben and I tried to be prescient here and assumed some of the things that we're going to talk about. We'll quickly run through these while Al gets his questions together. And I think we have talked about this notion of shifting your focus from reactive to proactive. And I don't know what the timeline was for you and your organization, but there was a time when it was acceptable to be sort of, oh, woe is us, what are we going to do? Confused and introspective. But then hopefully quickly you moved to being proactive and said, I wrote some notes about this. Remember, what was it? Give us 1 week, 2 weeks, whatever it was to flatten the curve. man, we barely remember that. It was so long ago. And so we really found at some point that let's be proactive. Let's not just sit and pity ourselves and admire the problem. Second thing is earn back the trust of your colleagues first and then regain the trust of your patients. That speaks to the confusion and the erosion of trust. And Kim, you really did a great job of talking about how you started your new job and responsibility. Get that trust back. Gay, listening to people and saying, what works for you? That's something they haven't heard their entire time in nursing. They haven't heard what works for you. It's all what works best for us and how do you fit into that? So, tip that upside down. And I think you guys have both mentioned how you've really seen some great benefits. Then we have to regain the trust of our patients. That still is something that we're a ways away from. And I'm going to plow through these. So if anybody wants to comment, just, let me know, but ask your medical staff how they're doing, how they're feeling, and then listen to them. And again, Kim, you talked about this and help if you can. Find a way to be responsive to their needs. We need these folks, and they are feeling like they've been taken advantage of, ignored, and imagine the tensions that they're experiencing with those specialties that make their living in the operating room and told, no, you can't have that surgical time because we can't. Your patients are going to go to an ICU bed and we need to leave that open for what might come in through the ER, et cetera, et cetera, et cetera. So, listen to your physicians. Fourth, humility looks good on everybody. I always used to say this, it really is important for us to be humble and curious because, when we portray ourselves as having all the answers and then, oops, that we don't have the answers. That answer is wrong, and that's what bothers me, frankly, about what we've seen coming out of the federal government and some of the agencies. There's been no humility. There's been no apology, and we've been wrong about everything. So I think we need as leaders to be humble and set the tone, listen and serve well. And then finally, err on the side of over communication and clarity. When it comes time for us to welcome our patients and visitors back into the facilities, realize that they're confused and fearful, and think of ways to welcome them back and make them feel comfortable about being back in your facilities, in your organization, and not fearful. So those are some takeaways that hopefully are helpful to you. And now back to you, Al, for some questions.
Thank you, Roger. And we do have a few. I'm going to throw the first one out there for the entire group. How do you suggest we best restart some important pre-pandemic efforts that have been paused, like colleague engagement, burnout, or improving access?
Great question. Great question. Who'd like to tackle that one? How do we restart some of these things we've had to put on pause because of the urgency of the crisis?
Roger, I can take a quick quip at that one before others do. A couple of things that came to mind just as you were going through some of those points you just did on the last slide. This idea of communication, especially. Now, you talked about communication with patients, which absolutely is a fundamental part of making sure that good care is provided and continued even after patients leave the venue where they are. But that idea of communication, I believe, is also fundamental as we continue to look at better ways of doing what we call access and orchestration. So this idea of providing access and what we were trying to do pre-pandemic, and again, during the past 2 years, has catalyzed how do we create access for people, whether that's to patients, to other providers, to the services that we provide within our organizations and across our organizations. And I believe communication is fundamental to that. And I think one of the most common things that I've been working with organizations from the technology side and then putting together great process with that technology is doing that very thing, facilitating communication as patients and providers are looking for where to get those patients to where they can get care, whether they're coming in from the ambulatory side into a hospital or going out from the hospital back to the ambulatory setting or to skilled nursing. It's very fragmented. It's very fragmented how we communicate verbally over phones, how we communicate over faxes, how we do phone tag back and forth. It's fragmented as to who's responsible for that communication as well. And so one of the things that I've really stressed with organizations that we work with is that as we look to bridge that flow of access and orchestration from pre-admission into hospital stay, through hospital stay, back out into the community, back to skilled nursing, and make that happen quickly and efficiently so we can, and I know hospitals are really interested in this, freeing up those beds so we can get the next patient in there and take care of them and decant our ERs and make sure that everybody's getting what they need, that leveraging great technology and great process to improve communication, minimizing the number of people that have to be involved in those decision-making processes, and making sure that we can free flow and get people through those communication barriers will really assist us in making those transitions more meaningful, more efficient, safer, and faster for our organizational needs.
Great, thanks, Darren. Gay, that I don't know if Gay, you had a comment, but that looks like real help to people who are struggling, doesn't it, to streamline a process? Gay, did you have a comment?
Yeah, to the question, colleague employee engagement is really a very important foundational element, as we've talked about. I do think it is worth, though, instead of just restarting programs that we had, I think we really need to take a look at where our employees are, where our providers are, and perhaps some of the work that we've been doing might have been right 2 years ago, pre-pandemic, but what is needed right now, when they might be not only weary, but spiritually and psychologically and emotionally damaged, there may be some deeper work that should receive priority and resource as you look at restarting that. So I would just urge people, take a look at where your folks really are and try to meet them where they are and help them, rather than just restarting what might have been stellar programs pre-pandemic.
And Roger, I know we just have 2 minutes left. Let me just add one quick thing, because I totally agree with what Gay's saying. So I have several clients who had different departments and areas and employees, literally, this came from employees, during the last 2 years that came up with a couple of really innovative solutions to things that they had never thought of before. And they've actually come to administration and said, now that we got our heads above water, what's the next thing that we could start working on? I mean, they actually want to re-energize themselves by continuing to do some innovative things. And I think if you start there and ask them what those are, let those few people or departments start, you'll start getting a groundswell from other people in the department. I know that's very concrete and pragmatic, but I think that's similar to what Gay was talking about.
Great, Chuck. Thank you for that. I think that speaks to our takeaway of being humble and listening. We don't have all the answers, so you share your thoughts. Thanks, Chuck. Al, do we have time for one more?
I think we do have time for one more question, and it's a two-part question for Kim and Gay. And the question is, what impact will the past 2 years have on the way we recruit and train nurses? And what will you be doubling down on for the future?
I'll start real quick. I think that how we react to the pandemic is going to reflect how we recruit. I think that there's a lot of people that I know of that have stepped up in the community and said, I want to go back and be a nurse to help the industry. And then I've heard just the polar opposite. I'm getting out of the industry because I don't want to face another one of these pandemics. And so I think how we react, how we come back and talk about nursing as a whole, how we treat nursing in the industry, I think will have a direct correlation to how we recruit and those that will go into the professions. So that's what I would suggest.
And I agree. And I would I would add to that, I think our relationships with those academic organizations that are developing, you know, all of the folks who are in the different disciplines that are on the interprofessional team, our schools of medicine and nursing and physical therapy and all of them, they have been disrupted in one way or another. Certainly students who were coming through in the last 2 years have significantly less clinical experience in many cases than what they have before. They're going to come to they're coming to our organizations now, really lacking some of the experiences working within interprofessional teams, working side by side with people who are in their desired discipline and so forth. They're coming to us with some real needs that are different than before. It's not the same transition to practice that it used to be. So I think we're going to need to collaborate a lot more on transitioning, working with academic organizations and transitioning, helping students to develop and ensuring that we have more reliable pipelines than, you know, perhaps what we've enjoyed in the past. But I think that's a relationship that needs serious work, and we need to work collaboratively rather than what has largely been separate.
Great. Thanks so much, Gay. Thanks to all of our panelists for your great questions and comments. We'll turn it back to you, Al, to wrap things up.
Thank you, Roger. And thanks to you, Chuck, Gay, Kim, Darren, and Ben, for such an engaging conversation here today. And as a reminder to everybody, if we did not get to your question, we will distribute them to our panelists who will respond to you by email directly. As a reminder, the Institute has a number of certification courses that are fully online and self-paced, including Lean Six Sigma, project management, diversity, equity, inclusion, and much more. To learn more about these courses and the 4 new leadership certification courses coming out next week, please visit us at baldrigeinstitute.org. Thanks to everyone for attending today. And as a reminder, the recorded version of today's presentation and the slides will be available on the Institute website early next week. And once again, thanks to all of our sponsors, especially members of the Mac Baldrige Society, who are trustees for the Institute for Performance Excellence. It is their generous support that makes these presentations like today's possible. Please be safe. Thanks, and have a great day, everyone.